Hello friends, welcome to my YouTube channel. This is a case of carcinoma cervix and its laparoscopy management, and I'm very excited today because during my PG days I never imagined I would one day be operating on cancer cases. Yet here I am, and it all thanks to the amazing teachers and mentors I have found along the way and have shaped my journey. This is type C1 nerve sparing radical hysterectomy, only my fourth such case, but I'll try to share what I have learned in past year and a half of laparoscopy, insights that made it easy and successful. These are the physiological attachments of the sigmoid colon, which I am mobilizing just to clear the surgical area. Now look at the traction I am giving and the counter traction my assistant is giving. And all you have to see is just yellow color line and cut above it. Always grasp the right point to give effective traction. Now this is just debulking, an extra step, not a compulsory one, but I just did for better exposure. Now our primary aim is to open all 6 avascular spaces. This is rectovaginal space between rectum and vagina. Here also we are cutting just above the yellow line because fat belongs to rectum. All we have to do is find the bubbles, and that is the correct plane, and just follow it. The significance of developing this space is that it will give us enough space while removing the upper part of the vagina and will also prevent any injury to the rectum. Notice how the traction is changed. Cut towards the lateralmost part of round ligament. Our target here is to find the ureter first. Here we are going towards left-sided paravesical space and pararectal space. Now here there was a small nick which happened to uterine artery, which spoiled the field, but you will see how I managed it. So before applying the clip, I safeguarded the ureter, applied the clip, and then only I released the left hand to look for the bleeder. Now just above the uterine artery, this is our second avascular space, left-sided paravesical space. Here also we are just following the bubbles and we can see obturator vein. This red color is the levator ani muscle which makes the floor of the paravesical space. Now between the ureter on the right side you can see the peristalsis and the internal iliac artery. We are going towards pararectal space. And our aim is to find out and isolate the inferior hypogastric nerve. This what I am holding is the left-sided inferior hypogastric nerve. Now the same mirror dissection on the right side. Now once you see the uterine artery, just go above it in the loose areolar tissue. Notice the change just after giving slight traction. Go until you find the floor that is made by levator muscle. Now again between ureter and internal iliac artery, that is gate to pararectal space, you can see right inferior hypogastric nerve, which is also a neurovascular bundle, so there will be a vessel along with it. Which is now isolated. Now the sixth avascular space, that is vesico-uterine space, or simply between bladder and cervix. Notice how the traction and counter traction is created. Now for the most important part of the radical hysterectomy, that is lateralization of the ureter, or you can call it ureteric tunnel dissection. Separating the ureter medially from its peritoneal attachments. Also separating it from the uterine artery. Now keeping the ureter under vision, thinning out the fibrofatty tissue over the anterior cervico-vesical ligament, which also forms the roof of the ureteric tunnel. Using the uterine artery for better traction and exposure, de-roofing of the ureteric tunnel is done while safeguarding the ureter. Now going for the ureteric tunnel dissection on the right side. So again, whenever you find bubbles, that means you cannot be in the wrong plane. Now you can see the deep uterine vein which will take medial to the inferior hypogastric nerve later. Again separating the ureter from its peritoneal attachments, but notice that we are refraining from holding the ureter itself and we are holding the peritoneum surrounding it. Coagulating the right anterior cervico-vesical ligament while safeguarding the ureter. Now approaching towards a very important step, which was also the basis for the strong criticism on the LSCC trial. Read about it if you don't know it. That is taking off deep uterine vein as well as inferior vesical vein, that we'll see in a moment, medial to the inferior hypogastric nerve when it is a nerve sparing radical hysterectomy. Only the fibers supplying the uterus are cut. This is the nerve that we are again lateralizing. You can see just beneath the ureter. Now these two areas where you can see a little bit oozing are the areas for deep uterine vein and inferior vesical vein respectively. You can see the nerve very clearly this side, which is being lateralized. Sacrificing the fibers supplying uterus only. This is the deep uterine vein that I am coagulating, coming below the ureter. and that is the area of inferior vesical vein that I have taken. Now in this case, I have tried vaginal closure with Endo GIA surgical stapler before colpotomy, that is enclosed colpotomy, and I have tried it for the first time to prevent the spillage of the tumor in the peritoneal cavity that can happen after opening of the vault. The stapler was fired after confirming that both the jaws are visible and waiting for at least 30 seconds. One more advantage is that you automatically get 2 cm of tumor free vaginal margin. Now the only thing that is left is bilateral pelvic lymphadenectomy, which happens to be my favorite. Clearing the medial umbilical ligament that forms the medial boundary. Then dissecting the internal iliac artery, which forms the lower boundary. You can see the posterior division of the internal iliac artery. Now starting from the bifurcation of the common iliac artery, taking the due care to preserve the genitofemoral nerve, which is also the lateral boundary. Cutting just the peritoneum lateral to the external iliac artery. finding the obturated nerve to preserve it, removing the lymph nodes just beneath the circumflex iliac vein or the corona mortis, which is the upper boundary. And something I have observed, that it is technically easier to shave off the lymph nodes from the vessels when you are coming from above to downwards and the vessels are being retracted like this. This is how an enlarged lymph node looks like, what I am holding just beneath the corona mortis. Isolating and preserving the obturator nerve. Now cutting open the vault which was closed with Endo GIA stapler with bipolar energy, and the key is not using harmonic here because that too can cause spread by the way of aerosolization of the tumor cells. Specimen retrieval is done in the endo bag. On the left side, genitofemoral nerve, external iliac artery, external iliac vein, obturator nerve, internal iliac artery and vein, ureter, inferior hypogastric nerve complex, same way on the right side, genitofemoral nerve, external iliac artery, vein, internal iliac artery, ureter and inferior hypogastric nerve complex on the right side. This is the final endo view. Thank you so much for the patient watching. I hope you have enjoyed. Thank you so much.